Welcome to our LASIK webinar. My name is Dr. Brian Zog. I'm a professor in ophthalmology at the Moran Eye Center here in the University of Utah in Salt Lake City. We're going to talk a little bit about LASIK and PRK today and some of the other things that can affect your vision. So we'll start off by talking about refractive surgery. This is a procedure that's done that changes the way that light is focused on the eye. The goal of refractive surgery is to reduce the dependence on glasses or contact lenses for vision. We'll talk a little bit about the basic anatomy of the eye. You can see here a labeled schematic of the eye. The front clear window of the eye is where refractive surgery happens. It's the cornea. Behind there, the colored part of your eye is the iris, and in the dark spot or the pupil is the lens. And then way in the back of the eye, you have the retina, the optic nerve, which transmit light to the brain so that you can interpret what you're seeing. Refractive surgery essentially works on the cornea in LASIK and PRK. This is the way that the eye normally works. Light hits the cornea, it refracts it a little bit until it hits the lens. The lens also refracts it back into the retina to focus onto the fovea so that you can have crisp vision. When you're nearsighted, the near point of the eye focuses light a little bit shy of the retina, and so the image becomes blurry as it hits the retina. In order to fix this, you have to wear glasses or contact lenses to focus the light on the retina. In farsightedness, the light is not refracted strongly enough, and so it falls outside the eye. And again, glasses and contact lenses can help to focus light onto the retina so that you see things clearly. Astigmatism is another problem of the eye. Most commonly it affects the cornea, but it can affect the lens, and it creates a blurred image that again is most commonly corrected with contacts or glasses. Presbyopia is something that happens as you get a little bit older into your 40s and 50s, where you need reading glasses to see up close. As you bring images closer to the eye, the lens normally focuses these images on the retina. As you age, the lens stiffens and can no longer do that, and so you need glasses to bring things closer in focus. When you look at a prescription, there's a few different components that you can see. There's the sphere, cylinder, and axis, or the three parts of a normal eyeglass prescription. The sphere essentially tells you are you nearsighted or farsighted. A minus will tell you that you're nearsighted. A plus on the front of that number will tell you you're farsighted. The cylinder is the amount of astigmatism that you have in your eye. And then the axis is essentially the direction of that astigmatism that the glasses are made to fix. There's a lot of different choices when you want to correct your vision, glasses being the most common, and contact lenses, and then you have refractive surgery to fix some of these issues as well. In laser refractive surgery, what we use is a laser called an excimer laser. It changes the shape of the cornea. It can treat nearsightedness, farsightedness, and also astigmatism. Things that the refractive laser does not do is change your risk of developing a cataract or other eye conditions such as glaucoma or macular degeneration. So why would you have a laser to correct your vision? The laser that we use, an excimer laser, is a cool ultraviolet light laser. It reshapes the cornea. It can be very accurate. And it doesn't weaken the structural integrity of the cornea or the eye. The picture on the right is a human hair showing how exact the laser can be at changing tissue shape. There's two different procedures that are done for refractive surgery using a laser. One is called LASIK, it's laser in situ keratomileusis. The other is PRK, which is photorefractive keratectomy. So we'll talk about the difference between those two. With LASIK and PRK, both of them have the same foundation where the excimer laser is used to reshape the cornea to try to help your vision become clearer without needing contacts or glasses. With LASIK, it treats nearsightedness, farsightedness, and astigmatism. A thin flap is created in the cornea. This flap is then lifted, and then the laser is applied to shape the cornea, and the flap is laid back into place. There's no sutures or glue that's needed to put the flap back into position. It seats there naturally. LASIK flap creation has come a long ways. In the past, we used a mechanical blade to cut the flap. Now the cut is essentially made with a laser. Has a little hinge on it that allows it to go back into position after the surgery. The laser that we have currently is the FS200 laser.
The flap is created by first forming a tunnel to avoid an opaque bubble layer, or OBL. The tunnel provides a path for the release of the gas and water generated in the flap creation process. Once the cleavage plane is complete, a side cut treatment is applied, allowing the Wavelight FS200 to create a standard flap in approximately 6 seconds.
That's a schematic of how the flap is created on the Wavelight FS200 laser. This video will take you through an entire LASIK procedure so you can see what that looks like. This is a video of what it looks like under the laser. So a suction device is applied to the surface of the eye, and then the laser is docked into that suction device. This is what it looks like from the surgeon's view. During the time of this section, your vision is very blurry. Things have gone black usually. And then you'll see the flap coming in here. That's the laser cutting the flap on the cornea. So it creates a very smooth, even flap. That's the full process of cutting the flap right there. So you create both flaps on each eye, one flap on each eye, and then we take you over to the second laser to do the treatment to reshape the cornea. Those are marks that are placed on the cornea. They're used to reposition the flap, so we know where the flap sits in relation to the outside of the cornea once it's lifted. See here the flap is lifted up, exposing the bed of the cornea that's used to treat with the laser. At this part you'll see some flying spots on the cornea, and that'll be the laser. That's the entire treatment there, and then the LASIK flap is repositioned and allowed to seal back in place. This procedure is being done by one of my colleagues, Dr. Amy Lynn, one of our cornea specialists here at the Moran Eye Center. So the second laser that's used after the flap is created is the EX500. It's an Allegretto laser. And essentially changes the treatment based on the contour of your cornea. It's a lot better profile for night vision and glare issues than previous generation lasers. And over half of the patients end up with 20/16 or better vision after 1 year of treatment.
This treatment algorithm provides a market-leading treatment rate of approximately 1.4 seconds per diopter, designed to automatically track movements of the eye with a latency time of just 2 milliseconds. The Wavelight EX500 excimer laser automatically adjusts pulse placement to provide patients with exceptional precision and safety.
A lot of people are worried what will happen if they move while they're under the laser, and this eye tracker is very safe and good technology. If you move your eye too much, it actually shuts the laser off. It'll track your eye for small movements of the eye. We use some machines in the clinic to help us with the laser treatment. They're called Wavefront Scanners. Wavefront essentially takes your cornea and really details the shape of it. Rather than just taking a best fit sphere, it kind of takes all the different shapes of the cornea and helps us understand what it overall looks like. There's a lot more than just LASIK in laser vision correction, and also in general in refractive surgery. There's more options than just LASIK surgery. The other procedure that we do most commonly is called PRK, or photorefractive keratectomy. In this procedure, the surface skin cells are removed from the cornea, and then the laser is applied, and the skin cells are allowed to heal back in over time. It takes about a week for those to heal in. It also treats the same things that LASIK treats: nearsightedness, farsightedness, and astigmatism. Intacs is another procedure that's not done as commonly. You can use it for nearsightedness or myopia, but Lasik and Prk are generally better technologies to use. This is rarely used for just treating nearsightedness. Implantable contact lenses are common in people who are not candidates for Lasik or PRK. Some people have thinner corneas or higher corrections and they fall outside of the treatment window for PRK or Lasik. This is a non-cornea based surgery, so we essentially insert a lens inside the eye. It sits right behind your iris. There's another version called the Verisize lens that actually hooks to the front of the iris. And you can use this to treat nearsightedness at this point. Astigmatism is not treatable currently, but there are some technologies coming out where astigmatism can be treated with these lenses. What if you're a little bit older? Refractive surgery is usually thought to be a surgery for younger people, but if you're getting up over 50, there are some different options. As you can see here, these are people who are using reading glasses and are struggling with some of their vision in everyday activities such as reading, using the computer, playing games with friends and things. So what happens when you want vision for distance and for near? When you're younger, you can compensate and do this, but as you get older, you lose that ability to see up close when your vision is corrected for distance. A common way to treat this is with something called monovision. Monovision allows us to place one eye in focus at distance and then one eye in focus at near. So it can give you that functional ability to see at distance and near. Another way to treat this, and monovision can be treated with contacts or glasses. Another way to achieve this is with something called a clear lens extraction. The lens of the eye is where the cataract eventually forms, but not everybody has a cataract until you're usually in your advanced ages. And so you can actually remove this lens before it becomes a cataract and place a new lens in there that can help achieve your goals as well. There are many different lens implants. The majority of patients have a lens implant that corrects at one distance, either close up or far away. They can set up monovision that way. Or there are also lenses that can provide multifocality and give you different distances in focus where you can see far away and up close without glasses. The reason to replace the lens of the eye in a clear lens situation is because eventually you'll form a cataract, and it creates one of the most stable options for long-term refractive surgery. This again is something that you would look into if you're older, not necessarily in younger ages. Cataract surgery is something that will happen to everyone if you live long enough. It's a clouding of the natural lens of the eye. In this picture, the white pupil is the cataract. This is a very advanced cataract. Cataracts are usually in your 60s to 80s. The colors become less vibrant. You get halos around lights, vision's blurry, and you have a harder time reading, especially in low light situations. There's a lot of new things that have come out in cataract surgery recently with multifocal lenses and accommodative lenses that can help give you good vision. The purpose of these is to provide that full range of vision where you can see things up close and far away. Depicted here is an image of somebody looking out a window, looking at a book on a counter, and also looking at a can up close. Those are three different ranges of vision that we have that can be achieved with these types of lenses. Reasons to have refractive surgery. A lot of cases, some people might medically have a reason to have refractive surgery, meaning their contact lenses, they're just not tolerant to them, or they have certain occupational considerations where having hardware on the surface of or on your face is not practical. Recreational activities become a lot easier if you don't have glasses or contacts as well. So the real key to refractive surgery is being a good candidate. And how do you know if you're a good candidate for it? Some things to know from your perspective: if you have a stable refractive error, if your glasses aren't changing very much, you do need to have healthy corneas. You have to be over 21 years of age. Realistic expectations, kind of understanding what your outcomes can be. Poor candidates: if your best corrected vision with your glasses or contacts is less than 20/40, you may not be a very good candidate. If you have ongoing eye disease like glaucoma, cataract, or retina disease, amblyopia or lazy eye may make you not a good candidate as well. If you have systemic diseases that are not very well controlled in pregnancy, those are things that we initially just say not a good idea to have refractive surgery. The real way to figure it out is to come and see us. You can schedule a consultation with us. It takes a couple of hours. We can map out your eyes, talk to you, examine you, and see if you're a good candidate for all these different options. We can essentially tailor the refractive surgery options to your situation. You want to come in with a little bit of preparation. We don't want you in your contact lenses if you wear soft lenses for a week or two prior to the exam. These can change the shape of your cornea and affect the imaging that we take. Hard contact lenses we want on at least 2 weeks before your visit. We may have you out of them longer after we see you on that first visit. What we're essentially doing at that screening consultation is we're seeing if your corneas are thick enough to handle removing a little bit of tissue. We're measuring to see how far-sighted, how much astigmatism, how nearsighted you are, the size of your pupil to see if you have any underlying eye diseases such as dry eye or cataracts. Laser surgery, just to understand what it is, it's outpatient. We use topical anesthesia. You do need a driver on the day of surgery. Most people do not have pain, but you can occasionally have some discomfort. You're on eye drops for anywhere from a week to 3 months. And typically we'll see you the day of or day after surgery at 1 month, 3 months, 6 months, and a year as kind of the expected follow-up. Some of the side effects to be aware of that are commonly reported: dry eye, especially after LASIK, decreased night vision, and fluctuation in vision. The complication rate of after LASIK surgery is relatively low. Our stats are seen here on the right of the screen. The national scientific data is on the left. You can see that some of ours match up and some of ours have less risks as well, complications. Corneal infection being one that you see there, 1 in 1,000 in the national data, 1 in 10 to 15,000 in our data. Flap complications, they happen about half as common in our data. The other things match up pretty well. We do not have patients who have developed keratoconus or problems with ectasia after our laser correction surgery here. All of our patients that have had LASIK have a best corrected vision of 20/40 or better in the data that we have mined over the years. So what's considered a successful outcome for you as a patient? Well, number one, it's being satisfied with the result. That comes from understanding what the expectations are, what are the realistic outcomes that we can achieve for you. Understanding the statistics: if you're a low correction, you have a higher chance of seeing better after the surgery than if you're a high correction. Those sort of things are topics that we'll address when you come see us. Also, avoiding complications would be a successful outcome. This kind of helps you understand where we are here at the Moran Eye Center. This is data from 2001 up through 2013. It just shows the range of nearsightedness in people on the top without astigmatism and on the bottom with astigmatism, and the percent of sort of the uncorrected vision after surgery. So in low corrections, you have a higher chance of being 20/20 or better after surgery than you do in higher corrections, and also in patients with higher astigmatism, you have a little less chance of being 20/20 without correction, but fairly good results with LASIK. PRK, also very similar results. Some of these numbers are actually a little bit higher, but overall the stability of both LASIK and PRK are pretty much equal. So from a patient perspective, what you should be coming to us with your goals and sort of expectations, it's really to eliminate or reduce the dependency on glasses or contact lenses. Unrealistic things to think about are having perfect vision in each eye or having instant results. Some of these procedures require healing time and management monitoring to help you achieve your expectations. This is a schematic of what our laser suite looks like. You see the bed in the middle there. It allows you to stay in one position for both the flap creation and the excimer laser treatment as well. This is what it looks like under the laser, so that you guys can see the tracker and lights that will look like when you're laying down. So this is a procedure that shows what PRK is like, and I'll kind of talk you through this one as well. So initially a little mark is placed on the cornea. We're centering the treatment on the pupil. A small well is placed on the surface of the eye, and this is filled with alcohol solution. The alcohol solution essentially loosens the epithelium for removal. That's the surface layer of the eye, the skin. This is on the surface of the eye for about 40 seconds. At this part, those skin cells are essentially wiped away, exposing the mid-layer of the cornea where the laser can apply the changes and reshape the cornea. From here, compared to LASIK, the laser does the same treatment. So you'll see those flying kind of bluish purple lights that are applying the changes to the cornea. You might be able to see that green blinking light at periods of time during the video. That's what you're fixating on during the surgery. Cool saline is then used to rinse the surface of the eye. Contact lens is placed on the surface, and a few medications are put in there, and that's the entire procedure for PRK. It's a little quicker procedure because there's no flap creation. Very comfortable procedure for the patients, very minimal pain or discomfort. So we would love to have you as a patient here at the Moran Eye Center. The way that I personally approach patients is try to think of you as a family member and how I would treat my own brother, sister, mother. We try to have an ethical approach and be compassionate about the care that we provide, and the utmost desire for us is to give you quality care that you can enjoy the results of having better vision. We appreciate you tuning into this webinar. And again, I'm Dr. Brian Zog, one of the ophthalmologists at the John Moran Eye Center here in Salt Lake City at the University of Utah. Thank you.